Melanoma Matters is an educational resource. The content represents our opinions and does not constitute medical advice. If you're a patient with questions specific to your situation, please consult your medical practitioner. We've done that. Hi, everybody. Welcome to Melanoma Matters. I'm James Larkin.
And I'm Sapna Patel.
So today we're going to talk about the phase 3 Ipi 10 versus 3 milligrams paper. So that's Patel and colleagues. But before we do that, Sapna, icebreaker question. We've just got back from ESMO 24 in Barcelona. So again, within the boundaries of acceptability, maybe what was your favorite moment of the meeting? Doesn't have to be academic.
Yeah, it's not actually. My favorite is just, I said this to you, but it's like being within vibrational energy of people that you hold dear. It just feels so different feeling. It's like you can feel somebody's heartbeat when they're next to you or when you're in the same space. The like belly laughs at dinner, that you end up hurting the next day because you laughed so much, not from drinking so much, but from laughing so much. That to me really was the best part. Non-academic.
Yeah. So I guess that all comes back to the value of face-to-face meetings, I suppose. Did you see that person who put the slide up with the carbon footprint or not of their travels? So I can't remember what it was, but I think they traveled by train from somewhere in Northern Europe to Barcelona. And then they said, this was on the title slide, 6 kilograms of carbon dioxide. And then they compared it, right, to a plane ride, probably just from Northern Europe to Barcelona. It was like 3,600 kilograms or something like that. And that's kind of quite tricky, isn't it? Because inevitably people are going to come from long distances to go to meetings, as they should. But then I guess there's a bigger question about, how you trade off these different things.
I actually think that came to light last ESMO. I want to say that was a very popular thing that was shown a lot, maybe in light of Charlie having prominence at last year's ESMO, but there was a whole thing about sort of carbon footprint. I vaguely remember Miriam Shalabi writing about her train ride and probably nothing about necessarily the carbon footprint compared to those of us that took a jumbo jet. But look, that's on a different industry to fix the, emissions and everything.
Yeah, agreed. It is quite a tricky problem as well. But anyway, right. So let's maybe talk a little bit about this trial. Maybe I'll let you do the citation and everything else in a minute. But before we do that, I remember this trial really well, actually, the Ipi 3 versus 10 trial, because at the time when it was recruiting, certainly in the UK, and I think in most of Western Europe, we had no access to Ipi at all or any kind of checkpoint inhibitor. So maybe what happened, I don't know exactly, is that maybe we had the trials, but there wasn't reimbursement. And there'd been expanded access programs, but they would have closed by then. So we just had this kind of crazy situation where we didn't have any access to checkpoint inhibitor. And we took ages to open the trial, probably sort of British bureaucracy type of issue, NHS, all that sort of stuff. And literally the trial was open in our centre for about 24 hours or 48 hours or something like that. But as you might imagine, we had a queue of patients waiting to go into the study. And I think within that 24 or 48 hour period, we were able to randomise like between 3 and 5 patients. Which
wow.
Testament to our research nurses, because that's not a small thing to be able to do logistically.
For sure.
So we put a few patients in, but I think it had been open in most of Western Europe quite a lot longer, and I suspect colleagues like Paolo probably were able to put far greater numbers of patients into the study. Let's talk about the trial. Do you want to say the citation and the trial design and everything else?
Yeah, and with a bit of jet lag here, so I'll potentially be just a little bit slow on the uptake. This is Paolo Ascierto and colleagues. Michele Maio, senior author, Lancet Oncology 2017, Ipilimumab 10 milligram per kilogram versus 3 milligram per kilogram correction, let me start again. Ipilimumab 10 milligram per kilogram versus ipilimumab 3 milligrams per kilogram in patients with unresectable or metastatic melanoma, a randomized double-blind multi-center phase 3 trial. And so this was on the heels of the Jed-Wolchuk study, the phase 2 dose-finding study that had looked at a number of doses. Even, there was dose finding down to 0.1, 0.3, 1, 3, and 10 milligrams per kilogram. And it did suggest that there was dose responsiveness. And of course, with that comes some toxicity responsiveness. And so this study was really trying to answer in a prospective way, do we see that? And we can circle back, but there was a pooled analysis done of 3 versus 10 versus other ipilimumab dose levels, 1,800 patients in that pooled analysis, also by Jed-Wolchuk. So, essentially well looked after. And there's a bit of conflicting results between this randomized phase 3 prospective trial and that pooled analysis amongst many different studies, if you will. So we can circle back to that. But what this study was 727 patients randomized 1-to-1 to IPI 10 or IPI 3. And essentially, you did see a significant improvement in overall survival here. Let's make sure I'm reading this correctly. Medium follow-up. Yep. So 15.7 months for IPI 10 compared to 11.5 months for IPI 3, with a confidence interval that stays on the lower side, underside of 1, and a p-value of 0.04. And of course, it was expected that you did see higher rates of expected toxicities or well-defined toxicities at this point in the 10 milligram versus the 3 milligram group. Colitis, diarrhea, we were still coding it at some point back then, increased ALT, with that would probably go your AST, so transaminases, hypophysitis, et cetera. So, serious adverse events, it comes down to 37% here, so a third of patients in the 10 milligram group, 18% in the 3 milligram group. And as we know with IPI, at these doses, there can be some deaths. So there were 1% and less than 1% of deaths in these groups. So that's kind of.
I was just going to say, this relatively short duration of follow-up, right?
Yeah,
this is from
14 months.
Lancet Oncology paper, but already at that relatively short follow-up point, you're seeing an OS benefit. And then I'm just sort of thinking about some of the other trials where we've got kind of more mature follow-up. Yes, we are seeing OS benefits, but sometimes it takes a bit of time to develop. So you see it straight away here.
Mm-hmm.
And I guess that's the same point again that I made at the start, that we probably didn't have much access to other potentially effective systemic treatments for melanoma. So this would have been, for most patients, I think, their kind of main shot at treatment. There might have been some single agent BRAF inhibitors around. I suspect that combination BRAF plus MEK wasn't around then. And of course, let's say you had access to vemurafenib, for example. That's just going to be the people who've got the BRAF mutation. So that's 40%. So, and I guess balance between arms, although I don't know if that was reported in the paper or not. But yeah. So I guess the other comment from me is that, by the time this trial reported, it sort of become an academic result, right? In other words, we were beginning to see efficacy from anti-PD-1s. Not long after, we were probably getting approvals, in fact, by then for anti-PD-1s. And so had the whole anti-PD-1 story not happened, this would have actually been a really, really clinically important result. But as it transpires, by the time it reported, it was interesting, but probably not that influential for practice. What do you think?
Well, I think that's right for general practice. We wanted to see this study because we wanted to confirm some earlier thoughts. As you look across our spectrum of treating melanoma backwards, I suppose you could say we use IPI 3. The original approval had maintenance there every 12 weeks. which actually I liked. I mean, I did like this idea that a new clone of T cells might need primary checkpoint blockade, again. Anyway, it's a longer conversation, I guess. But it's approved 3 milligrams per kilogram in combination with PD-1 with no maintenance of the IPI. Moving backwards to adjuvant, it's 10 milligrams per kilogram with maintenance for several years of therapy, not just 1 year of therapy, but 3 years, up to 3 years, though we know most patients don't take it that long. And then in the neoadjuvant setting, it's gone even lower to maybe even 1 milligram. And in combination with PD-1 in the adjuvant setting, it went to 1 milligram for reasons we had discussed on another episode, which is really actually deductive to see how they ended up at that dose. But for us to know that more is important for so many reasons. There are certain scenarios where you do need more, certain rare melanomas, certain, the incidence or the development of brain metastasis, we wouldn't want to use less of an effective sort of swing. And I think anyway, let me just stop there. That's just like a short comment on it's nice. I think, back to your point, had PD-1s not hit the scene, we would have been playing around with dosage, maintenance, reinduction, all sorts of things with IPI. And in a drug that is responsive to more exposure, an area under the curve, that's actually interesting. There's lots of ways you can play with that. Hyperfractionation. There's a lot of ways we could have potentially played with this dose. Then it started getting combined with a dose that really does not show as much dose responsiveness. PD-1 sits on its receptor and is there for a long time. And then we've kind of stopped investigating the IPI dose, but I don't think, academically, I don't think the science is done there. I think there's more to do with IPI dosing, CTLA-4 dosing.
Yeah, I completely agree. And the rechallenge thing's actually quite interesting. Maybe just to make a quick observation about that. We've sort of known from a lot of the original work in IPI in people who'd had some benefit from IPI, and let's say that then had a couple of years they weren't on treatment or something like that, and they progress and you treat them again. Very clearly, you can have efficacy, and I still see that in clinic today. There are a few reimbursement issues there, but this kind of patient, where they clearly are truly, let's say they developed acquired resistance to anti-PD-1, so you've been treated for a while, and then they become acquired, and then if you are able to re-challenge with IPI in that situation, bearing in mind by definition you weren't, I still see in clinic today, a worthwhile level of efficacy. And maybe the other point there is that if you're following these patients really carefully in clinic, they're progressing down the line on anti-PD-1, your trigger to think about re-challenge will often be in someone who actually doesn't necessarily have what you might call quote unquote bad disease. In other words, you'll see some progression, but it's not the same patient as you might see coming in at the front door with a heavy burden of disease and high LDH. And I've certainly found quite a lot of efficacy, and I think that the data say this as well, in thinking about IPI down the line, if you can, if they've previously had benefit.
Yeah, it makes me think of the data we just saw at ESMO, the Keynote 06, that says, re-challenge with even PD-1 can get you a second bite at the apple, if you will. But there is something to me about IPI, and part of it goes to when you have resistance on PD-1, what is the mechanism of which that tumor is developing resistance? If there is some thought that the immune system is exhausted versus just has sort of left the party, if you will. There's I'm curious your take. There's progression of disease or PD-1 refractoriness that is new tumors developing. And there is PD-1 refractoriness that is your existing tumors shrank and now they're coming back to size again and maybe even beyond what you started with. So there's progression in your existing lesions and there's progression in new lesions. Do you find any one of those phenotypes to be more sensitive to ipilimumab reinduction?
Not that I've noticed, but I guess this is all anecdotal.
Yeah.
Yeah, and also, I should probably think about that a little bit more actually, but yeah, I haven't really noticed any pattern. Other than what I would say is that, now we've got anti-PD-1s and stuff, there can be a certain amount of nihilism about Ipi, because obviously single
Oh,
agent anti-PD-1 is better than single agent Ipi. That's not even a question, basically, but actually can be, a valuable treatment, I would say, if you can access it. And that's a nice way to think about it. If you have some Ipi, maybe your immune system gets invited back to the party. I'll have to try and remember that.
I mean, as people who enjoy a good party, come on now. So what I will say is, if a patient develops resistance on PD-1, what goes through my mind is, how do I bring T cells back to the party, recognizing that the first thing that might shut them down, if it's a new clone of, activated T cells, first of all, how do I bring them back, but how do I get them activated? I guess that's really. And then secondly, the first thing that's going to shut them down is CTLA-4 expression. So sometimes, and of course I have the luxury in the US of playing around with kind of treatments and sequencing, is somebody has resistance on PD-1, I might try some local ablation or something to one of these progressing tumors to sort of release new antigens. So whether it's radiation or intralesional or some sort of cryo, some sort of ablative therapy, if you will, to release some neoantigen, recognizing that might draw some activated T cells over. But then what I'm going to need is CTLA-4. And so that is sometimes how I think about reusing CTLA-4. But of course, I wouldn't use CTLA-4 really on its own. I would use it with the benefit of using it in combination with PD-1, because not only do we know that single agent PD-1 is better than single agent Ipi, we have certainly extrapolated and seen from long-term survival that combination of both is better than, certainly PD-1 alone, but certainly Ipi alone.
Yeah, absolutely. So, maybe the final point from me on this actually is the follow-up to this, the 5-year follow-up for this trial.
Yeah.
Which was in, I got it, Journal of Immunotherapy of Cancer 2020.
Nice.
Paolo Ascierto, again, is first author. Michele Maio is the senior author there. So now 61 months of follow-up. And, as you'd imagine, the medians for overall survival were pretty stable. But the hazard ratio for overall survival was actually remarkably similar after 5 years of follow-up. So 0.84, and again, confidence intervals not crossing one, statistically significant. So actually, that's strikingly similar.
Can I ask you, since you have it in front of you, is it 36 months where you're seeing a plateau? Or before that?
Yeah, so figure 1 from that paper is OS, and IP10 is in yellow and IP3 is in blue. So separation of the curves is around about 6-9 months, something like that. And then the landmarks, 1, 2, 3, 4, and 5 years. 1 year there's a 6% difference, 7% at 2 years, 8% actually at 3 years. And then it's pretty stable after that. But, the question of whether the curve is flat, if you just look at IP10 between 3 years and 5 years, you've got a drop off sort of 31% to 25%. So kind of fairly flat.
But still.
Not completely flat. But then I think you're getting into issues of melanoma-specific survival. Maybe that's a little bit early to think about that, but I don't think we can completely ignore that, because there's, the further out you go, the more that's going to factor into what you're seeing in front of you. And obviously now we've got 10 years from Checkmate 67, where we've really, kind of thought quite a lot about the difference between overall survival, melanoma-specific survival. Anyway.
Yeah, well, maybe, and just to circle to that, since you brought it up, do we need to be designing our clinical trial databases to capture MSS and OS moving forward?
Yeah, I think ideally, if you've got the trial, the kind of trial where you really do anticipate long-term follow-up, and I guess it depends on the trial. And then we've talked about this before, and the resource implications for long follow-up and so on and so forth. But
let's be honest, so many of our sponsors want overall survival as a primary, secondary, or just a captured endpoint. So that already implies follow to death, right? whatever resources or lack of resources they give you to do that follow-up. I guess the point being is most of these databases have a folder that just says, is the patient alive or dead at last follow-up? And you nip that little box and that's the end of it. But more importantly is if you nip the they are deceased at this last follow-up, that you ask a little bit more detail. What did they die from melanoma? Yes, no. How, I don't know if we can have a how certain question, but I don't know. Are they alive or dead at last follow-up is just too binary. It's fine for regulators. That's what they want is OS. But I think what we saw with Checkmate 067 is, if these patients are dying of other things, the difference in MSS and OS, recognizing that probably at the time that study was designed, MSS capture was not perfect. So this is a little bit of going backwards and asking for data that, sites either really did or did not collect properly. But if there really is that delta there between MSS and OS, we're better off it's 1 or 2 questions additive in that folder.
And listen, I think that would be, a really simple thing to do. And of course, we all know in the real world, the binary question isn't always easy. But if you think about how you report SAEs, for example, then you can have, did they die from melanoma? Yes, no. And if it's kind of not sure, then you just grade a degree of probability based on your judgment. That would be fantastic. And I think very, very little extra work. So that's a nice idea. So listen, that's go on. I was going to say that's 22 minutes, but you've got something else to say.
Yeah, I was just going to say that there was this pooled, analysis of long-term survival data from the phase 2 and phase 3 Ipilimumab trials. This is Dirk Schottendorf, first author, Jed Wolchuk, senior author, JCO in 2015. So before this phase 3 from Paulo was published, and this pooled analysis had 1,800 patients in it. And in this report, there was no difference between median overall survival in patients who received IPI-3 versus IPI-10. There were about 965 patients who received IPI-3, 706 patients who received IPI-10 milligrams per kilogram. So not small numbers. They list all the trials that they pulled this from in table 2. And I think this just highlights for me that pooled data is interesting, but because of the heterogeneity of the trials and maybe the populations and maybe where those trials enrolled, just so many variables, there, a randomized phase 3 trial or a well-done randomized phase 2, as Jeff Weber told us on one of our podcasts, it's his favorite trial design, one of his favorite trial designs. A well-done randomized prospective study really is our gold standard. And so, pooled analysis could be hypothesis generating, but where I'm going with this. I just feel a little hesitant to draw sweeping conclusions from pooled data that is really not the same as a meta-analysis and really not the same as randomized prospective trials.
Yeah, I mean, agreed. And I might even go a bit further, but I'll come back to that in a minute. But, before I do that, I would just say that figure 1 from this paper is kind of almost iconic. This is one of those figures where if you had $1, right, for every time, it's like the Webergram and the Rebergram, which I hope we won't need to fact check because we've done that before, and also that cartoon as well from the Melman review.
It's your immunity cycle.
Checkpoints, right? I reckon those might be the top 4 things that people like to show when they're doing talks, or at least they used to.
And the Weinberg of cancer,
Oh yeah, that's true, but that's not melanoma specific. Anyway, so I mean, I agree with all of that, and I'd go one step further to say that in this pooled analysis, this is a load of trials that have been done basically according to industry standards, right? If you see what I mean, in terms of conduct, in terms of data collection and everything else. And so another thing in there, and you'll have gathered where I'm going on this as well, is that if you've got academic trials with the best will in the world, they may not always be done to necessarily the same high standards. So I think you're going to get a little bit of drift there potentially on data quality. And I don't really think that's a controversial statement, actually.
It's not, but we never say it. We don't ever say that, but you're right. That's this figure 1 is the academic or sorry, the industry standard reporting. Ideally, they didn't vary from the first time they had it, as a Meta-X study to the last one they did as a BMS study, though there could have been some drift in data collection, as you say, but certainly between academic institutions, drift in, investigator initiated academic studies. Yeah.
Yeah. Well, I mean, number one, we are saying it now. Whether anyone's listening is a separate question. And I think also this isn't a criticism. I mean, academic studies are incredibly important, but the nature of the resources available to do them means that inevitably they're not going to be as stringent. Never mind, regulatory and other considerations with sort of industry studies. So, yeah, now 26 minutes, Sapna, is that enough? Or do we do more?
This is good. So dose matters, right? As you like to say, size of the dose matters. I'm being careful.
Yeah, well, that's maybe a great take home.
Yeah.
And I guess this is the first one we've recorded post ESMO 2024 as well, and you've had jet lag and stuff like that. So good job.
Thanks. All right, see ya.
Cheers.